orthopedic deformities associated with the Chiari-1 malformation. Thank you very much. I'd like to thank the Besta Foundation for this excellent congress and Dr. Valentini for her invitation. I'm especially going to talk about scoliosis because this is the most important and major deformity associated with Chiari-1 malformation. What we see as orthopedic surgeons is if there is scoliosis associated with a Chiari-1, we will always see a cord, single melia, lipoma, or tethered cord. We'll always see that. I've never found a scoliosis associated to Chiari-1 without any alteration of this type. I found one case in the literature, but I thought that that child had an idiopathic scoliosis, perhaps unfortunately associated with a Chiari-1. What is scoliosis? It is a complex deformity of the spine, and I'm sorry, I didn't even see that the slides. Okay, the slides are now going. This is what we said before, associated with syringomyelia or a lipoma. And what we see from a clinical point of view is that there are atypical classic curves, thoracic left curve, which is high, or double or a triple thoracic curve. As I was saying, sclerosis is a dynamic, complex alteration of the spine, which leads to alteration in 3 spatial planes. And what happens is a rotation of the pieces and the components. So the behavior of the curve patterns, we see a typical curve, left thoracic, double or triple thoracic, hyperkyphotic thoracic spine. These are indications for MRI because radiographically we can't see anything. We just think it's an idiopathic sclerosis, but at MRI, practically always you have a spine defect. And what, in fact, we found in the literature and also in our experience is, in fact, there isn't a real line between severity of syringomyelia and progression of the scoliosis. Sometimes we have considerable syringomyelia almost without very much scoliosis, but also I recently saw a tethered cord without scoliosis. And if there is, however, it does progress. That doesn't mean that syrinx doesn't lead to scoliosis, but there doesn't seem to be any evidence that the two are directly linked. So the evaluation is left thoracic curve, and another thing that we assess is the abdominal reflexes. When we have an absence of abdominal reflexes, this might be sign of a syrinx. And in this case, we ask also for MRI to be carried out. Symptoms, well, you all know them. They've been mentioned many times. I'm going to skip this. Treatment. Treatment of Chiari-1 when associated with syrinx, tethered cord, or lipoma is the first approach is neurosurgical. Not the orthopedic approach for obvious reasons, and a brace, however, doesn't really do anything if it is progressive. It might slow it down, but it doesn't definitively treat it. In the literature, I found this is not my work, I found several works. In fact, I thought it was a good idea to show you to them for the reflection it has on scoliosis, where you have syringomyelosis with the sclerosis. If you have early decompression of Chiari-1 malformation with syrinx and sclerosis, very often the sclerosis is stabilized. In other words, the patient doesn't need to be treated for scoliosis subsequently. Orthopedic treatment. Orthopedic treatment, as I said before, the brace is not sufficient to stop scoliosis if it's progressive, but can be a choice to delay the necessity for arthrodesis. Orthopedic evaluation once decompression is being carried out. As I said, there are some cases when sclerosis can in fact stop, but there are also many cases in which after decompression sclerosis doesn't stop. Anyway, there are assessment parameters to see whether this scoliosis is in fact progressing or not. So over 10, if you have a double thoracic curve and a kyphosis of more than 50 degrees or vertebral rotation of more than 2+, we know that we use the Nash-Mo score method. Here you can see the vertebral rotation. This is normal. When it starts to rotate, the one goes up, the other one's going down, and you see this effect. So from a 6 months interval of X-ray, if it goes from a B to a C, it's obvious that the sclerosis is getting worse. The advantage of neurosurgery, improvement of symptoms, first of all. When it's done at the right time, it can also arrest scoliosis, and also it has to be done before orthopedic treatment, because having vertebral fusion, if you have a tethered cord, a Chiari, before you untether or deal with a syrinx, obviously you risk creating a very, very severe spine damage. Treatment, as we said, I said rare, but in fact I've never seen it without the associated lesion, quite frankly. So the treatment is vertebral fusion. This is carried out to avoid worsening of the scoliosis, and in particular, where there is myelomeningocele, we know that 80% of patients with the myelomeningocele, we know that these develop scoliosis. So when should we operate scoliosis? When we have a curve that is more than 45 degrees and in the subsequent year has worsened by 10 degrees. This is an indication to go to surgery. When you do vertebral fusion, obviously you have to carry out an arthrodesis of all the vertebrae until the stable ones, where the scoliosis ends, in other words. So it's a very wide arthrodesis. A very long segment is fused. If the curve is very stiff and more than 90 degrees and the RISA, in other words, the amount of growth on the iliac crest is more than 2, then you have to, in fact, do this to avoid further problems. And during the operation, we use evoked potential, measuring the angles or the degrees. This is Cobb's system. From the vertebra at the beginning of the curve, you have a parallel curve to the flat one, and then the right angle, and this is the Cobb angle that we measure. This is the RISA sign. When you see 1, 2, 3, 4, 5, you have closure of the epiphysis. And in myelomeningocele, we associate the anterior procedure. The arthrodesis we can do here is better. So just to release and to correct the cartilage of the plate helps with the arthrodesis. An increasingly important problem is that of children who are under 10, because what we have seen is that at 8, younger than 8, fusion is not indicated. But if we look at a graph, in fact, our spine continues to develop, and therefore respiratory capacity, in fact, continues to develop. If you do arthrodesis in a 10-year-old child, you are sure that you are, in fact, giving him respiratory insufficiency for life, because that respiratory capacity won't suffice him for when he gets becomes an adult. So you have to wait, and therefore, then, however, you have to try and offset the possibility of having a very bad curve. Today, however, there are systems which allow us to treat these children without arthrodesis. One of these systems is the Vector, which is a vertical expandable prosthetic titanium rib invented by Mr. Campbell, and this instrument has the advantage that it is fixed to the rib or the pelvis, or between one rib and another. In fact, it was invented to deal with thoracic failure, and then it was adapted to scoliosis. And here there's a little sort of slide that a couple of times a year I can lengthen, and I follow the scoliosis of the child without putting braces, without causing arthrodesis, and I bring him to the right age at which I can carry out fusion. These are operative images of the vector growing rods. Dr. Banya has invented these. Here, the system is instead of fixing it onto the pelvis or the ribs, that you fix it to the vertebrae. So I do a foundation like this, I fix it, and the rods or bars go outside. I mean, we don't detach even the muscles. In the middle you have little cylinders. A couple of times a year I lengthen my cylinders, and therefore I maintain my correction of the spine without arthrodesis. So I guarantee the possibility for the spine to grow, the child to grow. Another possibility is stapling, invented by Randy Betts. And so what did he say? It's like epiphysiodesis. I block a growth nucleus, and so I allow growth on the other side. Therefore, I put a stable at the convexity, and therefore my spine will grow on the side of the concavity. This is a system which fascinated everybody to begin with, but it didn't prove to be quite so useful, because the vertebra, in fact, it doesn't have a defined metaphyseal area like a tibial plate, for example. So histological studies have shown that it's more pressure of compression of the vertebra and the disc, rather than blocking that part of the vertebra's growth. And unfortunately, it's seen that after time, these stables created lysis of the vertebrae, and they tended to mobilize. This is in thoracoscopy. Now, the instrumentation that can be used to treat scoliosis is therefore hybrid. Depends on the scoliosis. I talk about it as, say, hybrid means. It depends on the scoliosis you have. You've got the double rods, the unit rod, pedicle screws, or I can use titanium screws, because very often these people have to do MRI, and if you put in steel, they can't. MRI is no longer useful. These are the unit rods that we use. We use it in neuromuscular scoliosis. This is a person with myelomeningocele. We use penducular elements. They are, in fact, fixed to the iliac wings, and we go right up to the second thoracic vertebrae, and in fact, they stabilize from the hips and right up to the shoulders, also because these people are in a wheelchair, so it gives them stability, and also they have an ITP pump, these people. In hyperkyphosis, here we used a universal thing with the two bars and the little hooks. This is a hybrid situation. This is a pre-post, a lad with myelomeniingocele. I showed you these two pictures not just to show you what a good result we've got, because that might in fact be questionable, but every time you think about having to operate on a young child or an adolescent, you have to think about the fact that when you operate, the spine in fact will become a rigid piece and segment when you do arthrodesis, and you have to think in the future. And therefore, if you've got scoliosis above 45, which goes up by 10 degrees, that's one thing. Very often I see scoliosis, for example, operated on if it's 40 degrees, and that sort of person doesn't necessarily have any more pain than somebody who doesn't, but you cause him problems, and the surviving vertebrae will have greater load and work, and therefore they will have early degeneration. So not always is the operation that we carry out an improvement of the quality of life of that person. We have to bear this in mind. This lad, in these conditions, in fact, played basketball, and he was in the championship team. Every now and again he had back pain. Now this is the result. After a year he started playing basketball again, but he said, I'm very happy, you see, but I don't play as well as before, he says. Now, having said that, however, we looked at, after 6 months, and using two questionnaires, one of the SRS and another of our institute, these questionnaires were administered asking about patients' quality of life. And we saw where scoliosis caused poor quality of life, the operation in fact improved quality of life. I apologize, this is in fact in Italian, and I apologize, and I just didn't have time to do it because I learned yesterday the slides had to be in English. But anyway, the maximum score is 5. Activity function was one of the lowest scores, because you have to remember that practically all these kids are in a wheelchair, and therefore their functionality is reduced. But in pain improves a lot, self-esteem, psychological profile, and so on. Another question that I haven't put here, which always makes us think a lot, and that is, would you do it again? Definitely yes, I don't know, no. Many who gave a high score said perhaps no, I wouldn't do it again, because this is a very difficult operation for them and their families. The subjective questionnaire had 27 questions, usually on everyday quality of life. Pain is the most sensitive criterion, because these people in fact have decubitus, and they can't they have pain all the time. So, and again, in the light of the relief of pain, we have all the other things that follow on positively. In fact, respiratory improvement, nobody actually admits that they feel that they breathe better. Complications, we see 14%, 2 rupture of the rods, 1 explantation because of infection, 6 ruptures you couldn't see. So in conclusion, treatment of progressive scoliosis in Chiari type 1 syndrome is associated with syrinx and MMC, and very often it is surgical treatment which is required, and of course here we have to have the neurosurgeon and the orthopedic surgeon involved. Thank you very much, Colombo. Can you stay back a bit, because there might be some questions for you? Yes? So, how aware are orthopedic surgeons made of the risk of syrinx? If you have a scoliosis, the orthopedic surgeon, does he realize that there might be syringomyelia there? I mean, how aware are they? I mean, I don't want to speak on behalf of people who are not here. But what sort of degree of awareness is there? Certainly, pediatric orthopedic surgeons do have this in mind. The non-pediatric orthopedic surgeon perhaps is less aware of it. That's perhaps my answer. Perhaps I might be wrong. I mean, there might be orthopedic surgeons that will leap at my throat if I say that. I think that we are a little bit more aware than you think. I confirm that not always are orthopedic surgeons aware. I'd like to ask, please, you carried out evoked potential monitoring, somatosensor monitoring, and also what Salah talked about. Do you do what he did? And do you use SEP as well as MAP, MEPs, because that's the only way to look at motor activity. And in fact, our orthopedic surgeons don't operate unless they do this. As yet, we don't do this, but I think we will in the future. Many of our patients, unfortunately, have peripheral neurological deficit already, so they've lost the function of the lower limbs. We are more interested in SAPs so as not to create a neurological bladder where there wasn't one before. In those patients that don't have this problem, now we use an empirical method which works. So when we put in a peduncular screw, for example, I touch the screw with a very, very low voltage instrument, and if it's the right place, nothing happens. Any other question? Thank you very much, Colombo.